Thank you
Okay.
so much. Thank you. Welcome everyone to this month's ECHO session, to the pediatric oncology nursing teaching session. We have come back after a couple of months after some conferences. Thank you to the team from Sayan Hospital for doing this. And we have our new coordinator, Dr. Shivani Patel, who's also a consultant pediatric hemato-oncologist working at Choitram Hospital at Indore. She will be coordinating the nursing teaching with us from this month onwards. Welcome, Shivani, and I request you to introduce the speakers and start the session. Thank you.
Thank you, Dhani. That was kind of you. So, today we are going to discuss febrile neutropenia and care of critically ill child. With us, we have speaker Dr. Radhini Mande. She is junior consultant in pediatric hematology oncology at Lokmanya Tilak Medical College and General Hospital, Sion, Mumbai. With her, from her team, Ms. Nikita Pawar will also be speaking. She is a staff nurse in pediatric hemato-oncology at Sion Hospital. So, over to you, Radhini.
Yes, thank you, ma'am. Good evening, everyone. So in today's presentation, I'll be discussing definition of febrile neutropenia, risk factors and risk stratification of febrile neutropenia, evaluation and management of patient with febrile neutropenia. I'll be briefly discussing fungal infections and catheter-related bloodstream infections. So coming to definition of febrile neutropenia, as the term suggests, fever in a neutropenic setting. So fever temperature is very important. So single oral temperature greater than or equal to 101 Fahrenheit or 38.3 degrees Celsius, or a temperature of 100.4 Fahrenheit or 38 degrees Celsius for at least an hour. If you're taking auxiliary temperature, the cutoffs are slightly different. It is 37.8 Celsius, single reading, or 37.5 Celsius for at least an hour. Neutropenia, as we know, absolute neutrophil count of less than 500 cells per microliter, or a count of less than 1000 with a expected drop below 500 in next 48 hours. So coming to risk factors, so there are certain host-related risk factors, disease-related and therapy-related risk factors. So host-related risk factors, any sick-looking child, any child with comorbidities, hepatic renal insufficiency, or child presenting to us with hypotension, hypoxia, pneumonia, neurological symptoms. If there's any past history of ICU admission or MDR sepsis, that's a risk factor. Then coming to disease, acute leukemia patients who are on induction chemotherapy, then immunosuppressive therapy such as high dose cytarabine, cladribine cytarabine therapy, then I2A block of MCP 841 protocol. Then any chemotherapy where we are expecting prolonged neutropenia, that is more than 7 days of neutropenia or profound neutropenia, where ANC is expected to fall less than 100 cells, low or decreasing monocyte counts, or any post-transplant patient, allogenic or even autologous for that matter. So these are certain risk factors, disease and therapy related. So treatment related, one more thing is which chemotherapy we are administering, like anthracycline at a dose more than 90 mg per meter square, or cisplatin more than 100 mg per meter square. Ifosfamide more than 9 gram per meter square, cyclophosphamide more than 1 gram per meter square, etoposide more than 500, cytarabine more than 1 gram per meter square. All these are highly immunosuppressive therapies. So all these are risk factors. All these patients who receive these chemotherapy are at a very high risk of developing febrile neutropenia. So why do we risk stratify these febrile neutropenia patients? The main aim to risk stratify these patients is to identify those patients who can be treated on an outpatient basis, thereby reducing the workload on the hospital. So coming to risk stratification, high risk and low risk FN. This is how we classify a febrile neutropenia patient. So what is a high risk FN patient? Any patient who has prolonged neutropenia. I mean, any patient in whom we are anticipating to have prolonged neutropenia, more than 7 days, or profound neutropenia, or significant comorbid condition, as I mentioned previously, like pneumonia or oral or GI mucositis, severe abdominal pain, nausea, vomiting, diarrhea, neurological changes, any renal or hepatic insufficiency. So low risk patients are, on other hand, those patients in whom we are anticipating just brief neutropenia. There are no comorbidities and child is clinically very stable. So those are low risk febrile neutropenia patients. Why are we classifying these patients? Mainly, as I said, to manage patients on OPD basis, and also the antibiotics what we give will be different in both these cases. So initial evaluation, whenever a child of febrile neutropenia comes to us, how do we evaluate these patients? First and foremost is we take the history of the patient. That is, we see which phase of treatment he is on. Either he is on intensive phase, maintenance phase of chemotherapy, then what chemotherapy he has received, and so that we can anticipate the degree and duration of neutropenia, whether the disease in remission or not, or whether there was a previous history of ICU stay, or whether this child had a previous admission where he had a MDR positive blood culture or past history of fungal infection. Also, some centers they do rectal swab to check the commensal flora, gut flora. Based on that, they decide what antibiotics are to be administered to the patient. So after taking brief history, what we do is we do examination. Most importantly is vitals. What we start with is the heart rate, then respiratory rate, BP, peripheral pulses. First, after examining the vitals, then we do general examination of the child. In general examination, very important in febrile neutropenia patient is you examine all the orifices. You check for all sinuses, whether there is any sinus tenderness. Orifices, you check for oral cavity, nasal cavity, you check the ear. You also see groin, perianal region. Then if the child is having a central line, you look for the exit site, whether there is any tunnel or tract infection, you look for that. Also, don't forget to look at the skin, whether there are any furuncles, boils. Also examine axilla. And last but not the least, a procedure site. In case if a bone marrow has been done a previous day or any other procedure, do examine the procedure site. So after examination, diagnostic test, what we do initially is what we send is a CBC, that is a complete blood count with renal function, liver function test, and blood cultures. Now, previously, what guidelines had recommended is to send two sets of blood culture from different anatomic site. That is a peripheral culture and a central. That is, we call a paired culture. You have to send culture from the central line as well as a peripheral line. But recent recommendations of 2023, they are not strongly recommending to send paired culture because peripheral pricks in children unnecessarily causes pain, and they can even isolate the skin contaminants, and the chances of peripheral culture coming positive and blood culture from central line coming negative is hardly 10%, not very high, that you'll get a peripheral culture positive while a central line culture negative. So current recommendation is preferably to send paired, but if not, you can do away with just a central line culture. Then cultures from the other side, like urine culture, and is indicated only if the child is symptomatic. And chest imaging like X-ray or NCCT, again, we do only if the child is having a lower respiratory tract infection. So what I said is, what we do is complete blood count. We'll send a culture, paired culture preferably, if not from just from the central line. And CRP, some centers do send CRP and liver function test and renal function test. So these are the two culture bottles. One is the pediatric culture bottle and other is the adult culture bottle. So this pediatric culture bottle is Bactec PF Plus culture bottle. It contains a unique media formulation of adsorbent polymeric beads which offer antimicrobial neutralization. And these bottles are FDA cleared for delayed entry up to 24 hours after bottle inoculation. And these bottles are used for recovery and detection of aerobic and facultative anaerobic microorganisms. Most important point is the amount of blood that you collect during blood culture. So there is a guideline for it. Like in pediatric, it is weight based. So up to 2 kgs, you have to send 2 ml blood. 2 kgs to 12 kgs, you send 4 ml of blood in this blood culture bottle, and 12 kg to 36 kg, you have to send roughly around 10 ml blood. And in adults, what is preferred is 20 to 30 ml blood in the blood culture bottle. So this is the adult culture bottle. It is called Bactec FA Plus. You have to collect at least 20 to 30 ml for adults. But in pediatric, as I said, 2 ml up to 2 kg. Then 2 kg to 12 kg, you have to collect 4 ml blood. And beyond 12 kg, that is 12 to 36, 35 kg, you have to collect 10 ml blood in this blood culture bottle. This, I said, culture of the other sites like stool, urine, CSF only if clinically indicated. Radiological investigations, X-ray is not indicated for routine initial evaluation of episodes of fever. Only if child is symptomatic. What we do, preferably in neutropenic patients, is a CT of the chest, that is non-contrast CT chest, and that is recommended after 96 hours of fever if the child is asymptomatic. If the child is symptomatic, we can do it on day 1 itself. So coming to management of febrile neutropenia. So what are the challenges that we encounter while managing febrile neutropenia patients? First and foremost, there's a delay in commencement of treatment. How much ever we counsel the patients, the first golden hour, as we say, in the management of febrile neutropenia, the antibiotics has to be administered within the first within the first hour of fever. However, patients do not report to us within first 1 hour. So main reason is that they give paracetamol at home and then the fever doesn't come, so they come to us the next day morning. And the second main important reason is that they do not understand the gravity of febrile neutropenia. So counseling is foremost important, like in management of febrile neutropenia. So second challenge is because the prevalence of malnutrition is very high. So with malnutrition comes the complications also. Then the risk stratification, which I just now mentioned, high risk and low risk FNs. Not all centers are following this risk stratifications. Uh, because based on this risk stratification, we can decide what antibiotics are to be given. So that is very important that we have to risk stratify all our febrile neutropenia patients. Then antimicrobial resistance, which we are struggling in and day out. Then new fungal infections are emerging and community transmissions of certain infections which we cannot prevent. And last but not the least, the cost which is involved with the management of febrile neutropenia. So as per the guidelines, what antibiotics do we recommend? So empirically, all high-risk patients, as per the recent guidelines, what they say is use monotherapy with anti-pseudomonal beta-lactam or a fourth generation cephalosporin or a carbapenem as empiric antibacterial therapy in pediatric high-risk FNs, and reserve addition of a second anti-gram negative agent or a glycopeptide for patients who are clinically unstable or when a resistant infection is suspected or for centers with a high rate of resistant pathogens. So in our center, what we are currently doing is any high-risk FN patients, we are starting them on dual therapy with an anti-pseudomonal beta-lactam or a fourth generation cephalosporin or a carbapenem depending on the clinical condition with anti-gram negative agent, that is aminoglycoside, plus minus glycopeptide depending on the clinical condition. For low risk patients, as per the recent guidelines, what they say is consider a step down outpatient management and oral antibacterial therapy they are advising. But at our center, what we are doing is we are starting them on monotherapy with an anti-pseudomonal beta-lactam. So how do you modify treatment in these either high risk or low risk patients? So initially, as I mentioned, baseline when they come to us, we send blood culture and the report of blood culture we get within 48 hours. So that 48 hours blood culture, if it is negative and if the patient is afebrile for 24 hours and the 48 hours culture is negative and if counts are recovering, then be it high risk FN or low risk FN, we can stop the antibiotics. However, if the patient, if the patient is high risk patient, then we wait for the count recovery. In low risk patients, irrespective of the counts, we can stop the antibiotics and discharge the patient. If the 48 hours blood culture is negative and patient is afebrile, then we can discharge the patient in case if it is a low risk FN. And we do not step up antibiotics solely based on persistent fever in febrile neutropenia. So modifications based on clinical focus. So when do we add injection metronidazole? So that metronidazole is added in patients with suspected enterocolitis, severe abdominal pain, or perianal infection. Then teicoplanin and vancomycin is added if we are suspecting a central venous catheter or port infection, or if there's any hemodynamic instability, if there's a skin or soft tissue infection, if a child is having pneumonia or MRSA carrier patients. So next is IV oral clindamycin. When do we add IV oral clindamycin? If there is any again skin or soft tissue infection, any mucositis, we add IV oral clindamycin. And fluconazole is again for significant oral mucositis where we are suspecting it to be a candida infection. So what are the indications to add a gram-positive cover? So gram-positive may what antibiotics are there? Vancomycin, teicoplanin, linezolid. So when do we add patients having severe mucositis, grade 3, 4, skin and soft tissue infections? Then a patient if has come to us with pneumonia, clinically if we are suspecting a PICC related infection or if there is a hemodynamic instability, we do add a gram-positive cover. Or in case if there's a previous culture growing gram-positive organism, in that case also we add gram-positive cover. So empirical antifungal therapy. When do we start antifungal therapy in a febrile neutropenia patient? So all patients who are at high risk for invasive fungal disease. Which are such patients? Those with AML, that is acute myeloid leukemia, high risk acute lymphoblastic leukemia or relapsed acute leukemia. Then patients having prolonged neutropenia, those who have received high dose steroid for a long period, those who have undergone allogenic transplant in first year after transplant without evidence of T cell reconstitution, those who receive steroid or multiple immune suppressive agents or to prevent or treat graft versus host disease. So all these cases, like we keep our antenna high for fungal infection. So mainly if a patient is admitted with us 96 hours, after 96 hours, if a patient is having persistent fever, in that case, we start evaluating him for fungal infection. So what we do is we do a CT scan, NCCT chest, to look for invasive fungal disease. Previously, we used to send fungal markers, that is beta-D-glucan and galactomannan. However, the current guidelines do not recommend to send beta-D-glucan and galactomannan if you're suspecting fungal infection. Main thing what we do is our NCCT chest. Abdominal USG is done only if there are any abdominal symptoms. And CT of the sinuses is again done only if clinically indicated. So as I said, in high-risk patients with prolonged 96 hours of febrile neutropenia, which is unresponsive to broad-spectrum antibacterial therapy, we initiate antifungals, that is caspofungin or liposomal amphotericin B for empiric antifungal therapy. So at 96 hour, we will add caspofungin or liposomal amphotericin B. Simultaneously, we will do NCCT chest to look for invasive fungal disease. In non-high-risk patients, what we do is if those patients are not on any antifungal prophylaxis, we consider deferring empirical antifungal therapy. Instead, we'll do a CT scan. If on CT scan, if there are any signs suggestive of fungal infection, only then we add antifungal agents. There is no role of adding empiric antifungal agents uh, in non-high-risk patients. Next, coming to cessation of treatment, as I said, in high-risk and low-risk patients, cultures, if negative at 48 hours and patient has been stable and afebrile for at least 24 hours and evidence of marrow recovery if present, be it a high-risk or low-risk patient, we can stop the treatment and discharge the patient. In low-risk patients, even without marrow recovery, that is, even if the counts have not come up, we can discharge the patient if child is afebrile for 24 hours and cultures are negative at 48 hours. So I'll take you through few cases. First case is a 2-year-old female child who is a case of AML and has received 2 cycles of high-dose cytarabine chemotherapy. Today is day 10 and she is having fever of 103 for 1 day. No other complaints. On examination, she is sick looking. Oral acceptance is poor. No focus of infection. However, BP is borderline low. So what further history will you ask in such patient? So first of all, this patient has received high dose cytarabine chemotherapy, so which is a highly immunosuppressive therapy. So this qualifies to be a high risk febrile neutropenia patient because she has received intensive chemotherapy. Clinically, the child is sick looking and hypotensive, and culture which we had sent has grown GNB, that is gram negative bacilli on peripheral blood. So management wise, we'll start this child. First, we'll check the vitals. We'll give bolus, that is NS bolus we will give, and continue her on IV fluids if required. If BP doesn't normalize after that, we may even add pressors. Antibiotics, we'll give meropenem and colistin and look for any focus of infection and continue supportive management for this patient. So after 48 hours, again, we will reevaluate this child. We will check whether this child is having fever. And if the child continues to have persistent high-grade fever, we will look for any other focus of infection. We will trace the culture and check in case if there is any MDR bug. Now, this child has grown a GNB, so we have to check the MIC if there is a MDR bug, that is minimum inhibitory concentration. So based on that, we can modify antibiotics. So if a child is clinically stable and persistent fever, in that case, you rule out thrombophlebitis, any other cause of fever like hepatosplenic candida, infusion-related fever, drug-induced fever, CMV. But if child is unstable, looking sick, then that time you have to escalate antibiotics. Then day 4, if the child continues to have fever, what we do is NCCT thorax to look for fungal infection. And as I said, we have to consider imaging of sinus or abdomen only if the child is symptomatic. So now after 48 hours, in responding patients, discontinue double gram-negative coverage or empirical glycopeptide that you have started. Do not broaden initial antibiotic regimen solely based on persistent fever. So in patients with persistent fever who become clinically unstable, escalate initial empirical antibiotic regimen to cover gram-negative resistant organisms and anaerobic coverage. So coming to case 2, this is a 9-year-old male child whose intermediate is BALL on interim maintenance phase day 27. He is presented in casualty with fever for 1 day with Tmax of 101. He is otherwise well child, no focus till now and no previous hospital admission, and rectal swab has not grown any organism. On examination, this child is vitally stable, general condition is fair, he is accepting orally. ANC is 0.42, not that low, CRP is 1.2, and we have sent the cultures. So risk stratification wise, this patient will be a low risk FN patient and we can manage him on outpatient basis. He has not received very intensive chemo, his counts are low, not very low. Initial culture is also sterile. Fever is persistent now till day 3. Will you upgrade antibiotics in such cases? So we'll not upgrade in such cases. We will continue same antibiotics. And once the child is afebrile on day 4, of course, we can stop antibiotics and discharge him. So duration of antibiotic is, as I said, in febrile neutropenia, high risk and low risk. If cultures are sterile, we can stop antibiotics. If 48 hours culture is sterile and 24 hours child is afebrile, and if there is count recovery, we can discharge the patient in high risk. But in low risk, even without marrow recovery, we can discharge the child. But there are certain conditions where you have to give certain duration of antibiotics. So in case of septic shock, if a child has come to you with septic shock, but the culture has not grown anything, in such cases, you give 7 days of antibiotics irrespective of your culture. Then if there is a soft tissue or skin infection, roughly 10 to 14 days antibiotics you have to give. Pancreatitis, again 7 to 10 days antibiotics you have to give. Enterocolitis is for 10 days. Empyema, if a child is having empyema, you have to give 21 days of antibiotics. In pneumonia, 14 days you have to give. And In case of culture positivity, if there's a gram-positive culture, you give 10 days of antibiotics. Gram-negative antibiotics, 7 days from the first negative culture, you continue antibiotics. So coming to third case, this is a 9-year-old male who's a known case of combined late relapse of BLL. He has received RES-BFM block F1. Today is day 12. He has come to casualty with fever for 30 minutes with Tmax of 104 with cough, cold and nasal discharge for 1 day. He's on voriconazole, acivir and cotrimoxazole prophylaxis and he is very compliant. On examination, general condition is fair, chest is clear, no added sounds, no hypoxia or tachypnea, accepting orally, and he is hemodynamically stable patient. And there is no past history of any MDR sepsis. So risk, how will you classify this patient? Risk and choice of antibiotic. Now this patient has received intensive chemotherapy. So he is a high risk febrile neutropenia. Focus in this case is respiratory. However, child doesn't have any lower respiratory tract infection like symptoms. Now initial cultures are sterile and fever is persistent till day 4. How will you manage? So initial management, as I said, we'll start the child on dual agent. One is cefoperazone sulbactam plus amikacin. This child is on voriconazole, so we send voriconazole levels for patients who are on prophylactic voriconazole to maintain the blood level between 1 to 5. So here we'll check the voriconazole level and we'll continue fluvir and azithromycin, which we have given for his cough, and we repeat culture. So how frequently do you repeat culture in febrile neutropenia? Every alternate day we send blood culture, every 48 hours. If the child is having fever, we send every alternate day, we send blood culture. If the child is afebrile, then there is no need to send. But the child, if he's having persistent fever spikes, you have to send blood culture every 48 hours. So in this case, we had sent beta-D-glucan and we had done NCCT thorax. So this is what on NCCT thorax we could see fungal nodules. So his galactomannan was sent and it was positive. So this looks like a invasive fungal infection of the chest. So what are the most common fungal infections that we see in neutropenic patients? 3 most common are aspergillosis, candida and mucor. So aspergillosis, particularly we know it causes pneumonia. It is mainly diagnosed by NCCT thorax. What you see is nodules. You can see crescent sign, air crescent sign, halo. They can come even with consolidation. Drug of choice for aspergillosis is voriconazole, and alternatively, you can use liposomal amphob, which is a broad spectrum antifungal. Then, second most common fungal infection is candida. Particularly, it causes catheter-related bloodstream infection. It is diagnosed by blood culture, and beta-D-glucan is high. Values are high, like more than 90 nanogram per ml in case of candida infection. Drug of choice for candida is caspofungin. And if caspofungin is unavailable, then you can give liposomal amphotericin, which is a broad spectrum antifungal. Then third fungal infection is the mucor. It causes rhino-orbitocerebral disease. It causes pneumonia. Treatment, because it is an angio-invasive fungal infection, treatment majority of the times involves surgical debridement plus liposomal ampho and posaconazole, because in azoles we know only posaconazole covers mucor, rest all vori and itra they do not cover mucor mycosis. So liposomal ampho is broad spectrum and posaconazole is the only azole which covers mucormycosis infection. So this is again a nodule which you can see here in aspergillosis pneumonia. Next case is that of a 10-year-old male child with Burkitt lymphoma. He's stage 2 group B. On before cycle day 8, presented to casualty with fever and respiratory distress. So this case again, the chemotherapy is, he has received intensive chemotherapy, so he's a high risk FN. Focus is respiratory, rectal swab is resistant. So management wise, what we have started, we have started this child on meropenem, amikacin, and teicoplanin because he has signs of lower respiratory tract infection, and we do CT chest in this case. Also, what we add is azithromycin for atypical to cover atypical bacteria, and oseltamivir to cover for viral infection, and O2 support we give, and this is how his CT which we did looked like. So we had sent his culture report, BAL we did, bronchoalveolar lavage in this case. So we had sent for pneumocystis cerevisiae, but however it came positive, and then we sent CMV DNA, which was positive. His he turned out to be CMV pneumonia. Sorry. Okay, so these were the 5 cases. Now I'll just briefly tell you about catheter-related bloodstream infection. So, what is the definition of catheter-related bloodstream infection? It's mainly isolation of same pathogen from a quantitative blood culture drawn through central line and from a peripheral vein with a single bacterial colony count at least 3 folds higher in the central line sample. Then same organism recovered from percutaneous blood culture and from quantitative culture of the catheter tip. There has to be more than 15 colony forming units. And there's something called as differential time to positivity. That is a shorter time to positive culture in the central line sample than the peripheral sample. That means the central line sample will flash 2 hours earlier than that of the peripheral line sample. So how do you manage catheter-related bloodstream infection? So main is systemic antibiotic lock therapy. There are certain indications when you remove the central line. So antibiotic therapy wise, we know gram-positive vancomycin is recommended. If MIC of MRSA is more than 2 mcg per ml, or if vancomycin resistant enterococci is present, then drug of choice is daptomycin. GNB, if detected, we can give either ceftazidime, cefepime, piperacillin, or carbapenem based on sensitivity. Fungal, Candida generally responds to caspofungin. So, what are the indications of catheter removal? So, if there is any hemodynamic instability, if there is a concomitant endocarditis or metastatic infection, if there's a tunnel site infection or thrombophlebitis, suppurative thrombophlebitis, or persistent bacteremia, even after 72 hours of appropriate antimicrobial therapy, then that is the indication of catheter removal. Then there are certain organisms which, if found to be positive, then you have to remove the catheter. First is Staphylococcus aureus, then drug resistant, that is your MDR GNB. If there is a candida in catheter, then you have to remove the line. And Pseudomonas aeruginosa, because they have a tendency to form biofilm. That is the reason why you remove lines in such cases. So when do you give antibiotic lock therapy? So any if your catheter has grown a gram-negative bacilli, but which is sensitive, then you can preserve the line. You can give antibiotic lock therapy and give systemic antibiotics. So, what is the rationale behind using antibiotic lock therapy? Yes, catheter-related bloodstream infection, it leads to biofilm formation on the catheter luminal surface. Antibiotic lock provides a concentrated antibiotic solution into the lumen to achieve a drug level high enough to kill bacteria within the biofilm. And why do we use heparin? Heparin is used mainly because it interferes with the fibrin formation and it allows increased antibiotic penetration in the biofilm. So what antibiotics generally we use in the lock therapy? We use vancomycin, ceftazidime, teicoplanin, amikacin lock. And dwell time, you all must be knowing it very well. Minimum is 8 to 12 hours and duration same as systemic antibiotic therapy. So this teicoplanin lock and amikacin lock is what I have just enumerated, but I'm sure you all are well aware of these locks. You all must be routinely uses. So this is how you, this is a protocol for your teicoplanin and amikacin lock. So, in short, to summarize, febrile neutropenia is an oncological emergency. First dose of antibiotics, as I said, has to be administered within the first golden hour, and antibiotic choice has to be based on the sensitivity, and we have to keep looking for focus, and we have to treat the patient and not the counts. Thank you. Now I'll request Nikita's sister, who's the staff nurse at Sion Hospital. She'll just briefly tell you about the nursing care in febrile neutropenia.
Dr. Radni, has Miss Nikita joined?
Hello, ma'am. I'm just checking with her. Just give me 2 minutes.
While we are waiting for Miss Nikita to join, if any of you has any questions, you can put in the chat box.
We're waiting
While
for
we are waiting, Dr. Radni, can you take up the questions in the chat box, please?
Yes. So first question is by Neetu Raj. Sister, hi, ma'am. Can you please explain about neutropenic care? So, see, first of all, a child who's having febrile neutropenia, like from nursing point of view, what you have to do is regularly check vitals of the child. Most importantly is the heart rate and BP because that will tell us how is the perfusion status. So you have to check the heart rate if the child is having any tachycardia. Like if the child is afebrile and he's still having tachycardia, then you have to immediately inform the doctor that he's having tachycardia even at when he's afebrile. Then secondly is BP because like in pediatrics we have BP centiles, so you have to strictly adhere to those centiles. And if the BP is dropping to less than 50th centile or it is near 5th centile, you have to immediately inform the doctor. Then you have to check the SpO2. Then input output is again very important. Like this is what you have to mainly manage. Like vitals you have to check and input output. Because sometimes like they have a lot of positive balance, and then these child become tachypnic. So you have to very meticulously monitor input output of the child. Then general hygiene care, as you counsel, it same applies for neutropenic patients also, like hand hygiene. Then oral care, they have to use mouthwash 3 times a day. Then they have to take clotrimazole tablets, that, or candid mouth paint 3 times a day. They have to use, and sitz bath. That is to keep the perianal area clean. They have to put povidone iodine solution in the tub of warm water, and they have to sit at least for 10 to 15 minutes for 3 times a day. So these are certain things which you have to advise in all neutropenic patients. And also regarding diet, what you have to counsel is that they have to take cooked food. Then, in case if they're taking raw fruits or vegetables, they have to remove the peel and then only consume. And mainly avoid junk foods and or anything from outside. They have to eat home-based cooked food mainly. So this is regarding diet, and in case if they're going out in any crowded places, they have to wear a face mask. So these are general, advice what you have to give to all neutropenic patients. Then second question is, child is in severe neutropenia, continuous fever. How frequently will you send blood culture? Yes, so this I had covered. Like if a child is having continuous fever, every 48 hours you have to send blood culture, whether it is positive, negative. I mean, you have to repeat. Positive culture, of course, you will send till you get a negative culture. And if the culture is negative, 3-4 times, even if the culture is negative and child is continuously having fever, you have to repeat every 48 hours. You have to keep repeating. And that is every alternate day you will send blood culture till the child is afebrile. Okay, so next question is, please explain about formula to count ANC of the patient. Yes, so ANC is your absolute neutrophil count. So what you do is, if your so if you have seen the CBC report mein they'll always, of course, hemoglobin, platelet, WBC count they will give. Now, suppose the WBC count is 10,000. Okay, and your neutrophil percentage they'll give. So this information is generally there in most of the CBC reports. So if neutrophil percentage is, you assume 50%, they have given neutrophil percentage. So how will you calculate absolute neutrophil count? So absolute neutrophil count is mainly this 50% of WBC. So 50 upon 100 into your WBC count, that is your 10,000. So that will come to 5,000. So your absolute ANC count is 5,000. Your WB, am I clear? Uh, so your ANC, absolute neutrophil count, how do you calculate? Is percentage of neutrophil, that is 50% of WBC. So 50 upon 100 into 10,000. So your absolute neutrophil count is 5,000. Okay, the next question is, any special CVAD care needs to be taken while in neutropenic period apart from weekly dressing? No, there's no special care. Whatever you follow routine PICC care, same you have to do. Only thing is that, and weekly dressing is acceptable, like for PICC. And if there is sport, monthly, at least once in a month, you have to do dressing, and no special care as such. But the neutropenic patient, so barrier nursing has to be maintained whenever you're whenever you are near a febrile neutropenia patient. If you're delivering antibiotics or blood products or strict barrier nursing has to be followed, and strict hand hygiene, very important is hand hygiene, that has to be followed. So ANC count is, what I said is percentage of neutrophil into total WBC upon 100, right? This is right.
Thank you, doctor. Thank you. Your nurse is able to join?
I'll just check once with her, but she's not answering my call. I'll just check.
I think we're running short of time also. I think we have had a quite a comprehensive talk from Dr. Radni, starting from the neutropenic precautions to management to including even antifungal, antiviral prophylaxis and everything. So it was very comprehensive, Dr. Radni.
Okay, thank you. I tried calling her, but she's not answering my call.
I think probably she's caught up somewhere. With the best interest of time, and as you've covered significantly, we'll just wait for a couple of minutes for the others to have any questions. Anyone else wants to ask any question or give your comments? Dr. Rajni, do you want to add any other points left out that you want to highlight? I think you've covered already enough regarding the topic. Do you want to add anything from her talk or anything?
I am actually, she has sent just now. I just checked. She has sent me few 2, 3 slides, but I can just read from that. This is okay. This somebody was asking regarding dressing, no, about PICC line care. So what she has, it's in there in one of the slide. Rest all I was just browsing, but it's more or less what I had spoken to regarding the general care of neutropenic patient. But this year, regarding the PICC line, chlorhexidine mucoshield 2% for side dressing, and we have to change the transparent dressing every 7 days. And if the dressing is dirty or contaminated, change it immediately. And we have to secure device to prevent dislodgement, migration, damage, or damage. IV tubing has to be changed every 24 hours. Yes, that's what That's the only thing. She sent me just 4, 5 slides. I think not the entire presentation. And hand hygiene that I'm sure everyone is very aware of. Hand hygiene. Yeah, somebody has asked in the box, sits bath for children below 10 years. Yes, in fact, children below 3 years, they enjoy a lot sitting in sits bath. So, 2 years, 3 years also at our hospital, we recommend sits bath for them. So, in fact, they enjoy sitting in sits bath. Any other questions from anyone?
I think that's it. And thank you so much, Radhi, once again. Thank you, Shivani,
Thank
for
you, Dharini.
having them with us. So with this, as there are no more comments, we will close the session. I'll hand over back to Himanshi to conclude the session. Thank you. Thank you so much.
Thank you
Thank
so
you.
much everyone for joining. Shivani, you want to add something?
No, I think it was quite comprehensive and lucid presentation, and thank you all for joining.
Thank you so much everyone for joining in. You can fill the feedback form that I have shared in the chat box. I'll be closing the session in next 4 minutes. So please fill the feedback form by the time. Thank you so much everyone for joining.